So, it's already been 5 years, which is kind of hard to believe. I think what I'd like to do for this roundtable is to just describe for each of us what we use it for, and more importantly, a lot of practitioners still use one single test. I think we've made that mistake at times when we started using the test. But I'd like to go around and talk to you guys about how you use the test today. And David, in surgery, you use it both. Do you use it pre-op or post-op mostly?
I probably use it more post-operatively than I do pre-operatively, and I'm looking for trends on, we know that surgery will have a peak in serum amyloid A, and it usually peaks again at day 3 after doing especially a large surgery. And what I'm looking for are trends that it's coming back down after day 3, and by day 5 and by day 7 it should be normalizing. And if it's not, then I'm starting to look for any of these postoperative complications that I've been hoping aren't occurring. But for me, the earlier detection of a postoperative problem leads to an earlier treatment and a better resolution of the case. So it's important for me to notice those things before the clinical signs. And so I'm looking, most often the surgical cases will peak at day 3. The absolute number on one test doesn't tell me that much, where if I see it trending up at day 5, I'm concerned, and I start looking. Am I looking for a thrombophlebitis? Am I looking for a surgical site infection? And as we get through more and more of these cases and the data, if we're trending in the wrong direction, we're finding what's happening, and then earlier institution of treatment, which really is going to get us better case resolution as opposed to burying the head in the sand and hoping everything's okay.
And Corinne, you're using it more pre-op than post-op, or you use both? Or?
For our electives, we're taking it pre-op as part of our routine blood work, so with our CBC and our chemistry. And that's dictating whether we feel like the horse is a good candidate for that elective procedure or whether we need to implement treatment before surgery or whether we need to hold off on surgery. For the colics, obviously that's emergency situation, but we also get at least our baseline serum amyloid A, and then we follow it up, and that helps us determine when we can cease antimicrobial use after surgery, and it also helps us determine if there's something else that we need to look at with the horse sooner. So do we need to look and see if there's a thrombophlebitis, or are we having incisional issues? Do we have a low-grade pneumonia, things like that, and we're catching those things sooner because we're monitoring the SAAs following surgery.
I think in foals, Jay, it's interesting. You were able to use some of the things that make us comfortable today about foal medicine, white count, ultrasound, but you were able to find some important things out with your study. Could you tell us a little bit about that? And whether trending SA is important.
Yes, so I have done a lot of work on Rhodococcus equi, which most commonly causes pneumonia in foals. And the industry standard right now for detecting Rhodococcus pneumonia prior to clinical signs is ultrasounding, thoracic ultrasound. And then when you find a lesion or you find an abscess in the lungs, traditionally, well, for the past 15 years, we've gone ahead and treated that before the foal has shown clinical signs. But we are definitely over-treating. We're treating way too many foals. A lot of foals would clear those lesions on their own. So what I did in a study is I was given approximately 100 foals that I was able to scan routinely, pull blood work on, and then analyze the data. And at the end of the year, see which foals went on to become clinically sick and which were able to clear the disease on their own. And when I looked back at the data, I was able to combine ultrasound findings with white count and with SAA, using a cutoff of 13,500 for white count and 75 for SAA. And if they met those criteria with an ultrasound lesion, they were much more likely to become clinically sick than foals that had blood work below those cutoffs. And that's a fairly low cutoff for an SAA when you're looking all over. But in this study, if we used the cutoff of 75 with a white count of 13.5, we would have treated very few foals unnecessarily, whereas when we use ultrasound alone to find Rhodococcus lesions, we're treating in excess of 80% of foals that don't need treatment.
So the addition of an SAA test and the evaluation of a cutoff number has dropped your antibiotic use in a herd situation by how much, you think?
Depending on the prevalence in each farm, from 50% to 70%. Dropping.
And mortality or morbidity rates are the same?
It's the same.
The same
Yes,
as before when you treated almost everybody?
Yes. I am very cautious, and we make sure everyone is monitoring the foals that we know have lesions with more of an eagle eye than they do their normal foals. But for 3 years implementing this procedure, I have not had a problem.
That's amazing. It's amazing to me that the addition of a new test that is, do you do 2 SAAs at all, or is it one on first day that you
I
examine?
usually do it the first time I find a lesion of a specific size, basically greater than 2 centimeters. Now, if the lesion is not improving on a recheck exam, then I will repeat blood work to see whether or not the white count of the SAA has gotten higher or if they're decreasing, and that might change how we're treating this foal. And by treating, I don't necessarily mean antibiotics, whether it's monitoring or actually implementing an antibiotic. But if the foal is improving on the ultrasound, because remember these are subclinical, so if it's improving on the ultrasound, I generally do not do another blood work, but if it's static, then I do go ahead.
So repeating diagnostics, not a crazy idea, right?
Saves using antibiotics, saves your pocket that way.
Mark, I heard this afternoon, your tour around the world with these incredible horses, that they literally went halfway around the world and back. How has SA changed your protocols? And do you ever use more than one? Or is 1-0 mean something, or 140 means something else?
Yeah, in our study, we had about 180 horses traveling around in total. And what we saw is that if the horse arrives clinically fine, and you test the horse after 24 hours, and you get a negative result, so SAA is low, then you can be very comfortable that your horse is healthy and will perform at his top level. Of course, if your horse arrives in a bad condition, so had a bad flight, then I would of course straight away test the horse and then use this test and follow it up and see what the level is doing, because most of the time we have a couple of days until the show actually starts, so we have a possibility to get the horse healthy again. And SAA changed my protocol in 2 ways. So I know all the time how my horse is feeling, even sometimes you don't see it from outside, and very often we have limited diagnostic possibilities at these shows. It's the one thing. And the second thing, I can also show the rider that we are on top of the case, and we know how the horse feels, and we do the best what is possible to get the horse ready for the show.
For me, in particular on the racetrack, I think respiratory cases are the #1 case that I use them on. I identify horses that need antimicrobials. I use the antimicrobials until they are no longer needed, based strictly on the SAA and clinical signs. And Rodney, I know you get a lot of bad cases because we send you a lot of them, but you, yeah. So has it really reduced your antibiotic use, or do you feel a little more confident when these horses are discharged? How can you mold that into what your practice is? Do you think it's actually less?
Doesn't necessarily change how many cases I use antibiotics on, but what it does do is, its use, day-to-day use in my clinical cases, just allows me to determine when, in conjunction with the other diagnostics, clinical findings, when might be the appropriate time to stop antibiotic therapy, or even when might be the appropriate time to switch that horse to a different antibiotic that I feel comfortable sending the horse home on. Typically, once once the SA starts trending downwards, and the horse is no longer having fevers, may still have some lung pathology on ultrasound, at that point I might feel comfortable switching it over to a less intensive antibiotic regimen that we can discharge the horse home on.
So is it fair to say it's made you more precise, more precision in your use of antibiotics?
I think it is definitely, in my years of practice, it's probably the one thing that's sort of revolutionized or changed the way that I practice in terms of managing the more intensive cases.